So today's lecture topic is Thyroglossal cyst. It's midline neck swelling, and as the name states here, it has got a component of thyro and glossal. So normally, what people think that it is something arising either from a thyroid gland or from the tongue, which is partly, I would say, it's not absolutely correct. Thyroglossal cyst is a different term. It's a different congenital anomaly. It's actually it arises from an unobliterated part of thyroglossal tract. Now, what is thyroglossal tract? We'll see in the next slide. It extends from the base of tongue to isthmus of thyroid, and it gives rise to the thyroid gland in our embryonic life. So, this is thyroglossal tract. This is base of tongue. This is foramen cecum, and from here, what happens that a tract in embryonic life, a tract comes down. This is tract, and ultimately it gives rise to the thyroid gland. So that is the reason why this tract is called as thyroglossal tract. It starts from the tongue and it gives rise to thyroid gland. So the name is thyroglossal tract. Now, after doing this job, this tract, it gets obliterated. What is the meaning of obliteration? Obliteration means any tubular structure, if it gets fused, it becomes solid. Then this is called as obliteration. So this tract doesn't disappear. This tissue doesn't disappear, rather than that the tract which was hollow in embryonic life, later on it becomes solid and it persists. Adults also. But in form of a solid obliterated tract. Now let us presume that in any person, any male or any female person, this tract, some part of this tract, it fails to get obliterated. As you can see here, I'm repeating it again. This was in embryonic life, and here you can see the whole tract has become solidified, but part of it, a small part of it, it has failed to get obliterated. Now this part, it won't be visible when the child is born. It is not visible. It's a microscopic condition. It's not visible by external examination or by X-ray or MRI. So you don't know that whether, even in me also, whether this tract is obliterated or not, I cannot say. Maybe that some part of this tract has failed to fuse. Now, in any of such patients, any of such person, we cannot call them as a patient till now, but any of such person, if there is gradual accumulation of secretion in this unobliterated part, so it may give rise to a cystic swelling in the midline of the neck, which is called as thyroglossal cyst. So I'm repeating that it arises from unobliterated part, which is here, unobliterated part of thyroglossal tract. In which person it will get unobliterated, nobody knows. And if it is unobliterated, in which persons it will give rise to a cyst, again, no one knows. So this is the cyst which is arising, and that's why it is a congenital problem. Doesn't matter, sometimes it may present in childhood or in adolescence or in adulthood, but still, because it is because of embryonic defect, it is called as a congenital problem. The location is important. Most common, it's in the midline, but again, it can be, we'll see in the next slide, it will be better visualized here. Most commonly, it is beneath the hyoid bone. This is subhyoid position. Second most common in the frequency is at the level of thyroid bone. And third one is suprahyoid bone. So this is a sequence. This is a probability. This is if you see a large number of cases of thyroglossal cyst, you will find in most of the cases it is beneath the hyoid, but in some cases you may find it is at the level of thyroid, and even in some cases it is above the hyoid bone, which is suprahyoid location. Here's another view. This is thyroglossal tract, you can say, and here is an unobliterated part. It has gives rise to a thyroglossal cyst. It's lined by pseudo-certified ciliated columnar or cuboidal epithelium. It's a true cyst. It contains thick jelly-like fluid. It's very thick and transparent. So transformation may be positive, but the fluctuation is very difficult to elicit because the content is very thick. It is surrounded by a shell of lymphoid tissue. Now, what is important of this point? We'll see in the next slide that the cyst is surrounded by lymphoid tissue, and what is the significance? And even the more important thing is that rarely it may contain the only functioning thyroid tissue. Again, we will elaborate these 2 points in our next slides. But for now, it is these are the pathological features of this slide. Clinically, it arises as a midline swelling, a slowly growing swelling in the midline of the nape. But in relation to thyroid, it can be, as you can see here, it can be slightly on the left side. It's a congenital swelling, but it may present at any age. Now, one common misconception which should not be there. Many people think congenital means anything which is right from the birth. No, not essentially. Congenital means anything which has resulted because of some defect during embryonic development. Now, this problem may be present at the time of birth or may appear after, say, few days, a few weeks, or a few months, or even few years after the birth. So it can present at any age, but mostly it is seen in children and young adults. As with the thyroid problem, this is also more common in the female, slightly more common in the female. It's a vertically ovoid cyst because it is arising from a tract. So the tract is like this, it is oriented like this. So this cyst is vertically ovoid. It is soft and cystic, as I told you, because the contents are quite thick, so fluctuation may be difficult. Whenever there is content is thick or it is intense, those swellings, the fluctuation test may be false negative. Transformation again, because it is transparent, so it is positive. It moves with deglutition. Now there are a few swellings which are arising from the larynx or which are connected to larynx. If you deglute, they move upward with the deglutition. So all the thyroid swellings, Thyroglossal cyst, suboid bursitis, these all are example of the swellings which move upward with deglutition. But the remarkable feature here is that this is the only swelling which moves up with protrusion of the tongue. We'll see in next slide. And again, because it is arising, don't forget that thyroglossal tract, it has not disappeared. It is still there. It is obliterated and it is still there. So that tract, if you hold this swelling by your thumb and forefinger, and if you try to move it, so it will move from side to side, but it will not be mobile in up and downward direction. I always compare it with an experiment of thread and the coin. That if you take a thread and place a coin in middle of it and you keep it tense. So what will happen? That in that condition, if you try to move that coin from side to side, it will move. But if you try to move it up down, it will not move if it is tense. That thread is tense. So any swelling which arises from some linear structure, like thyroglossal cyst or carotid body tumor or some neurofibroma or some vascular mass or related to some ligament, if it is attached to arising from or attached to a linear structure, it will be mobile in the perpendicular direction to that structure, but not along with that. So same principle is here. It can be moved sideways, but not up and down. So here you can see all the swellings which arises from this larynx or trachea, or if they are attached to it, then they will move upward with deglutition. So in Thyroglossal cyst, if you ask the patient to swallow the saliva or to drink, take a sip of water, it will move up and down. But as I told you, there's a long list of swellings, not a long list, but there are several swellings which move upward with deglutition. But Thyroglossal cyst is the only swelling which moves upward with the protrusion of tongue. You ask the patient to take his tongue out, you will find that the swelling has moved upwards, and when the moment patient takes it back, it goes back to normal position. The reason is that this tract is still there. It is obliterated, but still it is still there. So when the tongue will protrude out, there will be traction on this tract, and this swelling will move upward with protrusion of the tongue. Now here are a few cases of thyroglossal cyst. Here you can see a vertically ovoid cyst is there. Another case, midline swelling, slightly left to the midline. This is in the relation with the thyroid cartilage. This is infected cyst. You can very well see here because of edema and because of well-defined margins. This is infected cyst is there. Now, what complications can occur? Naturally, a patient who has got a thyroglossal cyst, if you ask the patient to go for surgery, he may ask you that why should I go for surgery, and what if I don't get it operated? So yes, there can be several serious complications. One is recurrent infection, because as I told you in the pathology, it is surrounded by a shell of lymphoid tissue. So lymphoid tissue is a favorite dish for bacteria. So there can be recurrent infection. The patient may this right now it is uninfected, but maybe after some time it has become painful, or I'm getting fever, or there is tenderness over the swelling. So infection can occur. Thyroglossal fistula can occur. We'll see in the next part that what exactly happens in the thyroglossal fistula. If it gets infected, then it may lead to thyroglossal fistula. And last but not the least, probably the most dangerous one, it can give rise to a malignancy. Don't forget that it's a true cyst. It has got an epithelial lining. So from that lining, malignant tumor can arise. So there are 4 major malignancies of thyroid gland: follicular, papillary, medullary, and anaplastic. So the malignancy which arises in thyroglossal cyst, most common malignancy is papillary carcinoma. Now, what is the treatment? And naturally, it's a true cyst, so you will have to excise it. Aspiration is not the treatment. Medical treatment is of no use. If you aspirate a true cyst, what will happen? That the patient may immediately feel that okay, the cyst is gone, but after some time there will be reaccumulation of fluid and there will be recurrence of cyst. So normally what we do, we go for complete excision of cyst, and that is the principle. With any true cyst, the treatment is only complete excision. If you excise it completely, then it's fine, otherwise it may recur. But here the complete excision is not sufficient, because don't forget that tract which is unobliterated, even sometimes in that tract also there can be some another second or third focus which is unobliterated. So if I remove, suppose if this cyst is removed, like any other cyst, like sebaceous cyst or adenoid cyst, but if you leave behind this tract, maybe that there is another focus on which the cyst may develop, and patient may come back to you after some time that okay, that part is fine, but I'm getting similar swelling little higher up. So this is that is the reason why only the excision of cyst is not enough. So you have to remove cyst along with the whole thyroglossal tract up to the base of the cecal, whole tract. But unfortunately, even that is not enough. Sometimes a small part of that tract, it passes through hyoid bone. And if you don't excise the hyoid bone, then it will give rise to recurrence. So ultimately, what you have to excise the cyst, you will have to excise the tract and central part of hyoid bone. If you do it, then only you can say that what you have done is cyst trunks operation. I'll show you cyst trunks first. Excision of cyst along with the whole of thyroglossal tract up to the base of tongue, including central part of body of hyoid bone. Cyst, whole tract, and central part of body of hyoid bone. This minimizes the chances of recurrence. So all these things should be removed. Then only you can say that I have done cyst trunks operation. This is operative photograph. You can see the tract is not a microscopy. It's a microscopic tract, but it is you don't have to do for microscopic surgery. All the tissue around this tract, you have to excise it. This is a case. This is cyst, completely removed because it is intact. So I'm sure that the 100% epithelium is removed. This is tract, and this is that central part of body of hyoid. Here you can see the tract has been damaged here, but this is cyst and this is hyoid bone. Now, ideally, if you are going for surgical excision, then if feasible, then you should always go for radioactive thyroid iodine scan. Why? See, the one thing is that if there is a congenital problem in that patient, that a small part of that thyroglossal tract has been left unobliterated, maybe there can be another additional very, very rare congenital problem that his thyroid gland is absent or it's not functioning. I'm repeating. There is a thyroglossal cyst, there is some part was unobliterated, and the patient came to you, say at the age of 20 years or 21 years, and he or she is saying that I'm getting a swelling over here, which is slowly increasing in size. But the patient's status is euthyroid. There's no feature of hypothyroidism or hypothyroidism. So we presume that, okay, thyroid is normal. But rarely there can be a condition in which the thyroid of that patient is not functioning. Rather than that, the only functioning tissue which is remaining in that or in that patient is the wall of that cyst, which is producing thyroid hormone. Now, hormonal thing is that if the mass is not very important, even small amount of tissue, if it starts producing the hormone, it can lead to the proper balance of that particular hormone inside the body. So you will not be able to find clinically, like in this patient, if there is a cyst, even if I'm palpating the neck, I won't be able to say whether the thyroid is present or not, or it is functioning or not. But if I have to, if feasible, I will go for radioactive iodine scan. Now let me show you two conditions in which these both are patients of thyroglossal cyst. They both were sent for radioactive iodine scan. This was the picture in first case. Normal thyroid, nothing else, no cyst here. So in this case, yes, this patient is having normal thyroid gland, but there is nothing, no problem if you do the cystern's operation. But in this patient, in second patient, the picture was something weird. It's like this. There is no evidence of thyroid gland. Yeah, but there is some thyroid tissue which is taking care of thyroid status of that patient, and that is inside the cyst only. It's a condition of diarrhea. If suppose you say, okay, if you say, I won't remove the cyst because there is no thyroid, it is inside, and the cyst wall is producing thyroid hormone for this patient. But what about all those complications? There can be infection, there can be rupture, there can be cosmetic. As one more thing, cosmetic problem is there. Nobody likes the swelling over here, and midline swelling which is visible to everyone. And papillary carcinoma can develop. So what is to be done in such cases? Such cases do exist, yes. And if thankfully, if you went for radioactive scan, then only you can find. Otherwise, you cannot find it preoperatively. Now, in such cases, what you will have to do, the best treatment is that you go for excision, but at the same time, counsel the patient before surgery. Explain that he has got, unfortunately, he is not having a thyroid gland, and this tissue we will have to remove. We cannot leave it behind. So, what he has to do, he will have to take thyroxine, thyroid hormone replacement for the rest of his life. So with this condition only, you can go for excision of thyroglossal cyst in such cases. If you say I'll aspirate, okay, if you'll aspirate, maybe after some time, what may be, the chances are very high that it will recur because epithelial lining it's not a false cyst, it's a true cyst. Epithelium is still there. It will start secreting, and after some time, the condition will be same. So if you are getting a condition in which in radioactive scan, it is seen that there is no functioning thyroid tissue and all tissue is there in the cyst only. So in that case, the best treatment is excision with lifelong replacement of thyroxine hormone. And the one point, if it is infected, as I showed you in one slide a few minutes ago, if it is infected, then first treat by antibiotic and then exercise. Don't drain it. Don't make any incision. Don't do this mistake. Treat it by antibiotic, and after a few weeks, when the infection and everything is controlled, then you go for cyst trunks operation. So this is what is done in case of thyroglossal cyst. You have to remove all these things. Now there is a list of swellings which move upward with deglutition. All thyroid swelling, thyroglossal cyst, subhyoid bursal cyst, enlarged pretracheal nodes, and laryngoscale. They all are either arising from larynx or attached to it. So these all will move. Any swelling arising from these of this list, it will move upward with deglutition. But there's only one swelling which will move upward with tongue protrusion, and that is thyroglossal cyst. Now coming to thyroglossal fissure. Now we saw that thyroglossal cyst is a congenital problem. It may present in few weeks or few months or few years. Weeks is usually rare, but usually presents in few years. So, but thyroglossal fissure is not a congenital problem. It is always an acquired problem. Same thing, same location. The only thing is that there was a swelling here, and here there is a small pit. Small opening is there. So it may result because of it is also called as median fistula, not the median, midline. It's a midline, so median fistula of neck. It's always acquired. It is never congenital, which may result from any of three conditions. Number one, spontaneous rupture of infected cyst. The patient has got thyroglossal cyst. There was some infection. There was some abscess formation. He didn't go for proper treatment, and after some time it ruptured. He was happy, okay, the pus is gone. But after some time he's saying that pus is okay, but there is continuous discharge from this opening. It is not healing. Surgical drainage. I told you just 2 minutes ago. If it is infected cyst, treat it with antibiotic. Don't put your knife on that. Don't treat it like an abscess. Because if you will drain the pus, it will lead to a thyroglossal fistula. And yes, not last but not least, if you have not excised it properly, excised it completely. Suppose you remove the cyst and only a part of it, and a part of it is left behind, it will lead to a thyroglossal fissure. Here you can see this is the fistula. You can the probe is inside it. It's a midline opening, and it is covered by a skin of hood. It is also called a hood sign. You can see here. Or a semilunar sign is also called. Semilunar means half moon. Inverted moon you can see here. If you go for a contrast study, if you put here, because you know that tract is still there. So if you put here contrast, this tract, the contrast will go inside the tract and it will go up to the base of the cecum. Base of the tongue, the foramen cecum. So thyroglossal fistula can be demonstrated by a radiological study also. Clinically, yes, there must be a history of thyroglossal cyst infection or excision. If not, then probably patient is lying. There must be some, he may be a child or maybe an adult person, but there must be some swelling. And he may say that it was infected, or I went to some surgeon and he excised it, he didn't excise it properly. So everything, there can be a history of that. It's a midline fistula. I already showed you. It's called a semilunar sign or hood sign because it is covered by a skin hood whose concavity is downwards. Discharge is mucoid. If it is infected, it can lead to mucopurulent discharge. Just like as with the thyroglossal cyst, this fissure also, it moves upward with deglutition as well as with tongue protrusion. In treatment, again here, same thing. You'll have to go for cistern's operation. And if infected, first treat it by antibiotics and then excise. If the discharge is mucopurulent, then start antibiotics and then excise it. So cisterns are here again. Now instead of swelling, you will have to remove a skin around it. So the operation is going on. This is swelling, this fistula, opening of fistula, and along with it, skin is there. And this is thyroglossal tract. And you excise it completely. You remove the same thing. You will have to remove the central part of body of hide bone. Also, you will have to remove the complete thyroglossal tract up to the foramen cecum. So this is all about thyroglossal cyst and thyroglossal fistula. Remember that thyroglossal cyst is a congenital anomaly, but thyroglossal fistula is an acquired condition. First, there will be a cyst, and there will be some problem in that cyst which will lead to fistula formation. Now, just a few words. With the same, almost same, at the same location, there is a swelling which is related to the subhyoid bursa. Beneath you see the sequence is hyoid bone, thyroid cartilage, cricoid cartilage, from up to down hyoid, thyroid, cricoid. So beneath the hyoid, if there is subhyoid bursa, if it gets infected, then it leads to a cystic swelling again in the midline of neck, which in relation of subhyoid bursa. Position is just below the hyoid bone. Remember that the commonest location of thyroglossal cyst is subhyoid. Here again, the commonest location. This obviously name itself says it is also. So both are seen at the same location. Now, what is the difference? This is horizontally ovoid. Thyroglossal is because it is related to the tract, so it is vertically ovoid. But here it will be horizontally ovoid. But it may not be a very remarkable or very prominent difference. Soft cystic fluctuant, both are there, transformation, okay. But the major difference is that this one will move upward with deglutition. When you ask the patient to swallow something, it will move upward. But if you ask the patient to protrude his tongue outside, it will not move. This is in contrast with what we had seen in thyroglossal cyst. In thyroglossal cyst, it was moving upward with deglutition as well as protrusion of tongue. But thyroglossal bursal cyst, it moves only with deglutition, but does not move with protrusion of tongue. So this point is not very important. If someone asks you what is the basic difference in how will you differentiate between these two, this should be your answer. You will ask the patient to deglute, both swellings will move. But if you will ask the patient to protrude out his tongue, only thyroglossal cyst will move. This will not move because it has got no connection with thyroglossal tract. And there can be some signs of mild inflammation. If it is bursitis is there, it may be present, and treatment is obviously surgical excision. But why I'm mentioning it here, that because you should know that at the same location, midline neck swelling, there is a long list of midline neck swelling, but beneath the hyoid bone, if you are getting swelling, then think of thyroglossal cyst or subhyoid bursal cyst. That's all for this lecture. Thank you very much.